Hello, my name is Dr. Timothy Kelsch. I'm an otolaryngologist here in Scottsdale. I've had a practice for around 10 years at Scottsdale Road and Osborn. And today I'm going to talk about the evaluation of thyroid nodules. First, I neither have any potential or actual conflicts of interest in the presentation. There are more prior to 1980, the evaluation of thyroid nodules was pretty much that you found a thyroid mass or nodule, and with concerning clinical characteristics, we would proceed to a diagnostic thyroidectomy. That would be taking the thyroid out to evaluate it under histopathology to see if there was thyroid cancer. And as you can imagine, this led to quite a few surgeries performed with benign disease. After the 1980s, with the introduction of fine needle aspiration and ultrasound, there was improved specificity and sensitivity to detecting malignancies and cancers. And because of these new technologies, the algorithms became a little bit more complex. Because of that, that developed a lot of controversy on what was the best way to evaluate the thyroid nodule and determine which nodules were concerning and which nodules were benign. We want to do that with the most sensitivity and specificity possible to alleviate any unnecessary surgeries. So at a recent conference, one of our more renowned thyroid surgeons, Dr. Ashok Shah, had mentioned that he felt there were more thyroid articles written than there have been thyroid surgeries performed. And although we know that's not true, I do appreciate his sarcasm on it. So in the objectives of this presentation, I do want to help us to assess the appropriate risk factors that would lead to an increased concern, identify certain characteristic on ultrasound and fine needle aspiration that might encourage us to be more aggressive in removing a thyroid nodule, and then review the introduction of new technologies such as biomarkers, which have changed the thresholds with which we might consider a thyroid nodule benign or more concerning. So this is our patient. She presents to her primary care with a lump or mass. Maybe her friend saw it on her neck or she felt it during self-exam. Certainly it's very possible that she's in for a routine examination and a nodule is palpated. And this then begins the concern of what is this new lump or bump in my neck? So in doing so, we can certainly reassure our patient that nodules are very common. 7% of the country will have thyroid nodules in adult patients, and over age 50, up to 50% of people will have thyroid nodules. So that conveys around 60,000 new cases of thyroid cancer diagnosed per year. Fortunately, a much smaller percent ever succumb to this disease, and we've stayed pretty steady at around 2,000 deaths per year. Incidental evaluation of the thyroid at autopsy has found up to a 4 to 10% incidence of thyroid malignancy in a patient who potentially was not symptomatic during their life from this thyroid cancer. So we do know it is quite prevalent, and the older we are, the more elevated that risk. It certainly is more common in women than men, as nodules are more common in women than men. But I will say that if a man presents to you with a new nodule, especially over age 45, the incidence that this will be cancer is going to be a bit higher than in women. 80% of all thyroid cancers are papillary thyroid carcinoma. That's something that's been changing over the years, likely due to increased detection. But there are other risk factors such as radiation exposure that we'll talk about later. Fortunately, with a thyroid cancer that is caught early and is well contained within a single lobe measuring less than 4 centimeters that has none of the more concerning characteristics, the 20-year survival is 99%. So the chance of them being treated and surviving free of disease is very, very high. So this is a patient of mine who presented with an enlarging neck mass that had been noted over about a week, was very firm, hard, and she had developed hoarseness and dysphagia. And with that, was very concerned that she had developed cancer. Because of the size of this mass, I elected to perform a CT scan, which isn't one of my more common evaluations, but I was concerned about this being something that was growing into her chest, and I wanted to know a little bit more anatomy. So here we see her CT scan, and it shows a mass in the right thyroid gland. I think it was measured at around 7 centimeters, but you can see it has a very smooth border. It's kind of pushing the thyroid around, not infiltrating it. It has shifted the trachea off to the left, and it's certainly distorting her neck. And between her clinical history and this finding, we determined this was more likely an intrathyroidal hematoma that had developed, or a hemorrhage into a thyroid cyst, and had a very good chance of being a benign process. So what are the concerning risk factors for thyroid nodules to be thyroid cancer? Some of the risk factors will be referred to me, some of the patients will be referred to me for these risk factors with concern that they had the symptoms first and then they were worked up for a thyroid source, such as hoarseness and dysphagia. And I will say, most commonly when we see people for hoarseness and dysphagia, I would say most commonly it is not thyroid cancer. But in the setting of a new nodule that has not been detected before, and during the workup, the patient notes that she has or he has had some hoarseness and dysphagia, I think that that becomes now a very concerning finding. Certainly a growing mass that is growing relatively quickly is kind of firm and fixed. That raises concern. A history of radiation exposure. So radiation exposure before age 20 does increase our risk of malignancy in the thyroid. We have learned from Hiroshima and Nagasaki, and as well, even some recent studies in Australia that were epidemiological studies have noted that up to the patients who are exposed to radiation before age 20, up to 30 or 40% higher risk of thyroid cancer is noted in those patients. Another concerning factor is a family history. If you have a first-degree relative who had thyroid cancer, you have a threefold risk of thyroid malignancy over the general population. Now, there are other things we have to be concerned about with regard to family history. There are several syndromes that are associated with thyroid cancer. That includes multiple endocrine neoplasia, Gardner syndrome, Cowden syndrome. Most of these are fairly rare, and the families often know about it in their family history. And certainly there are other symptoms and signs that there is a condition going on. Lastly, we have signs of spread, pulmonary nodules, adenopathy, or swollen lymph nodes in the neck. These things will raise our concern that this may be a cancer that is spread, certainly in a pulmonary nodule that has not previously been worked up. And then lastly, if that hoarseness is identified to be a vocal cord paralysis on the same side as the nodule, that would be a very concerning finding. So in our next evaluation, we also consider ultrasound findings as a concerning risk factor, and we're going to discuss that more. So first, we discuss the differential diagnosis of a thyroid nodule. There are benign nodules and malignant nodules, and the majority are benign. I would say by far the most common is our colloid or follicular nodules or thyroid cysts. And there are characteristics on ultrasound that can make us fairly confident and sure that that is what we're dealing with. There are other benign diseases like Our Lady, who we suspect has an intrathyroidal hematoma. Amongst the malignancies, there are 6 primary categories. We have papillary carcinoma, follicular carcinoma, medullary carcinoma, anaplastic, and then metastasis, which typically include breast, kidney, or melanoma, and then lymphoma. So the workup is actually, I think, relatively simple to begin with. We want to know the general status of the thyroid hormone production, and we want to know some of the architecture of the gland. So we will start with a TSH and an ultrasound of the thyroid. The TSH is primarily to determine if it has a low TSH in the setting of hyperthyroidism. In that setting, we might think that our nodule has more to do with a hyperfunctioning nodule, which has a low risk of cancer, as opposed to a nodule that isn't functioning. In our euthyroid patients or even our hypothyroid patients, then we proceed with our workup in this manner. So next would be the ultrasound, and then we have some other adjunctive evaluations, including scintigraphy, fine needle aspiration, and biomarkers, which we'll talk about in a second. So ultrasound is by far the workhorse. We're going to order an ultrasound. The patient's going to go to the radiology suite typically, and you're going to come back with a report. And though you don't do that ultrasound yourself, you're going to read the report, and I want you to be able to recognize the words that should raise concern in your eyes. Benign characteristics of thyroid nodules will refer to a more hypodense nodule more consistent with the surrounding thyroid tissue. And so there are certain findings that we will find, such as a spongiform appearance. And then cysts. Cysts have a very low incidence of malignancy, and cyst, especially a pure cyst or a partial cyst that has mostly a cystic quality with a comet tail, as they'll describe, has a very low incidence of malignancy. Higher risk and concerning features may be first purely size. Greater than 2 centimeters does increase the risk of malignancy. A more hypoechoic or solid, as that would relate to, a nodule would be more concerning. And then microcalcifications, little calcifications within the thyroid gland, which I will explain why those are there later. And then irregular margins. We'll describe these irregular nodules as lobulated or spiculated or even infiltrative. And these are just describing something that doesn't seem to be obeying the rules within its own thyroid gland. Taller than wide, our thyroid gland has an anterior-posterior dimension, and the nodules that seem to be more anterior-posterior long as opposed to wide, superior-inferior dimension, have a higher risk of malignancy and therefore convey a more concerning nodule. And then lastly, if on ultrasound you can see that this nodule seems to be poking its way out of the gland, extending into the surrounding soft tissues, that is a very concerning finding. So I show you here a microcalcification, some white punctate dots within what is a mostly isoechoic, maybe somewhat hypoechoic nodule. And that will relate to what we call Simoma bodies, which we'll discuss in a minute. So the American College of Radiology decided that it wanted all of their radiologists to speak the same language to you, because you're going to receive this report and read about these nodules and want to understand which ones are worrisome and which ones are not. And so they came up with the Thyroid Imaging Reporting and Data System, the TIRAD system. And most of the radiology departments I have worked with now have adopted this, and they will actually report their nodules specifically and then relate the TIRAD score. And all that TIRAD score does is add up all those concerning features I talked about and then not add in the unconcerning features and come up with a score that seems to be more concerning for a nodule that could have thyroid cancer or malignancy. So on this scoring system, I was able to give a copy of their actual scoring system. You can see, if you look closely at this, that there are higher points for nodules that have microcalcifications or extrathyroidal extension or seem to be taller than they are wide, and those convey some of the highest points to the overall score. And when that score is over 7, then you are at a TIRAD 5, which really suggests that a needle biopsy of this should be performed. They have guidelines on where they thought those needle biopsies should be performed, and these are more guidelines. Certainly, a TIRAD 1 is a benign appearing thyroid. A TIRAD 2 is most likely going to be a cystic nodule or a spongiform nodule. And then at 3, we start to get these more hypodense nodules that have a very, very sharp border that seem very non-infiltrative. And then when we get to 4 and 5, we start displaying these other characteristics I told you about, which include abnormal margins, extrathyroidal extension, and certainly microcalcifications. So the takeaway I want you to remember from this is some of those concerning words and the concerning size. So greater than 2 centimeters, is it more solid or hypoechoic? And are the characteristics of the nodule irregular, taller than wide, or extending outside the gland? And then there's one additional one when a nodule has calcifications in a rim and those calcifications are broken through, they call that a disruption, and that's also a very concerning feature. With these, I would say, the more concerning the features, the earlier you want to do a needle biopsy. With a lot of the high-risk features, we'd want to biopsy down to around 1 centimeter. And with the lower risk or the intermediate risk features, we may want to wait until closer to 1.5 or 2 centimeters. Scintigraphy was a very commonplace way of evaluating thyroid nodules previously, and if we're still doing that for thyroid cancer evaluation, it's more of an introduction to 2020. At this point, the American Thyroid Association has recommended that scintigraphy only be used if the TSH is low, indicating we have a hyperthyroid patient, and most likely we have a nodule that is autonomously overfunctioning. It's working too well, and that conveys a lower risk of malignancy. It still might require surgery, but at least we can give our patients more information. Otherwise, scintigraphy is not used for the evaluation of nodules. So after we get this imaging, we need a next step. Maybe we had a patient who had some concerning features on their thyroid nodule. They've noted it recently with some other clinical symptoms, and we certainly want to get some more information. So our next step would be fine needle aspiration. Fine needle aspiration is recommended to be done with ultrasound to more accurately penetrate the nodule. It's typically recommended from a 22 gauge to a 27 gauge needle. The higher the gauge needle, a 27 gauge is going to have less blood to contaminate the evaluation of the specimen, but have less cells. And a 22 gauge is going to have more cells, have more blood and have more cells. So some people choose somewhat intermediate, the 25 gauge needle. I rewrote on this slide to kind of recommend that in high-risk nodules, ones that have some of these features I mentioned to you that are very concerning, especially something like microcalcifications or extending out of the thyroid gland, that we lower our threshold to do a needle biopsy. And in some of those high-risk ultrasound studies, they've shown up to 70% incidence of cancer with the appropriate features. So early biopsy on the more concerning features, and definitely for those intermediate features over 2 centimeters, you want a biopsy. And then for the very low risk, a pure cyst, we're just going to watch. Additionally, needle biopsy is used commonly in the lateral neck for head and neck evaluations. And so any pathologic lymph nodes that are noted during the evaluation of a thyroid nodule should be also biopsied. But that's probably true regardless of whether or not we're evaluating the thyroid nodule. Ultimately, needle aspiration is taking cells out and looking at them on a slide using cytology, histopathology. And so it is subject to error in interpretation. In general, it's not recommended to biopsy more than 2 nodules at one time. It increases the false predictive rate of the needle biopsy evaluations, and then false positive predictive rate, and you're more likely to adventure into the possibility of benign disease being encountered and still evaluated with surgery. And it's also not recommended to biopsy a functioning nodule, one that's overfunctioning. So I thought I'd just give you a picture of the most common one that we will find, papillary carcinoma. And it's the most it's the cancer that the pathologists have the most consistent time diagnosing. In this slide here, we can see that these cells are surrounded by a scant amount of colloid, that they have a kind of a powdery chromatin with prominent nucleoli, some cleaving of cells. And in the bottom right, you can see where it came out in like sleeves of tissue, almost like it held the shape of the thyroid needle. Whereas in a benign needle biopsy, you'll have more of a gummy background with interspersed follicular cells that would suggest more of a benign process. Here we see some intranuclear inclusions. And on histopathology, you can see those Simoma bodies we discussed, which are the calcifications that develop within a thyroid gland, within a thyroid nodule that has cancer. Follicular carcinoma, I showed you here the needle biopsy of a follicular carcinoma, but typically that is a difficult one for them to diagnose by needle biopsy. We'll discuss that in a minute. With follicular carcinoma, you're going to see on needle biopsy these very crowded nuclei that are kind of in syncytia, just like an acina of the thyroid might actually have. Anaplastic, this one looks very disorganized. It's very hypercellular, but it's very disorganized, and the nuclei are very irregular. So in understanding, just like the American College of Radiology understood there should be some uniformity for ultrasound evaluation, the National Cancer Institute realized there should be some uniformity in the reporting of needle biopsies. So the Bethesda fine needle aspiration system was developed by the National Cancer Institute, and it was a rating 1 through 6. It's a little misleading because 1 is non-diagnostic. 1 isn't necessarily good, it's not bad, it doesn't tell us anything, and it probably will need either repeating or further evaluation. 2 is benign, and with the evaluations of needle biopsies and the ultimate evaluation with diagnostic thyroidectomy, they were able to determine that less than 3% of people with a benign diagnosis will end up having cancer. 3 and 4 are going to be our most controversial areas. We'll discuss that in a minute. And 5 and 6 are a high suspicion for malignancy. These are a lot of these are going to be papillary, medullary, or anaplastic, mostly papillary because it's the most common. And they're a fairly strong degree of confidence by the pathologist that they have cancer. There is more likelihood for the pathologist to undercall one of these and shift them into categories 3 and 4 and skew some of the numbers that the National Cancer Institute wanted. So they've tried to make these uniform, and so this is the reporting system. So 3 and 4, category 3 includes atypia of undetermined significance and follicular lesion of undetermined significance, FLUS or AUS. And these are suspicious. They certainly have an incidence that if we did thyroidectomies on all these patients, somewhere between 5 and 15%, depending on the institution, would have cancer. And that's high enough that we definitely need to evaluate these further, but also low enough that there's going to be a lot of unnecessary surgery if we just operate on all these patients. Category 4 are follicular neoplasms or Hürthle cell neoplasms. And those can either be benign if they haven't ruptured through the gland or invaded a blood vessel, or they can be malignant if they have. And so there is a percentage of these that are malignant a bit higher than the grade 3. Together, when you look at this whole scale, we're basically saying that 70% of the time we can come up with a very accurate diagnosis. But it's the 30% that can have unnecessary surgery. And that's really where the focus of the next level of evaluation has been. So traditionally, if we had a FLUS or an AUS, we would do surgery, take out that thyroid lobe, evaluate it with either an intraoperative frozen section or a permanent histology, and determine if it's cancer. But now we may have something better. We have genetic testing of that tissue that we removed to see if there is a higher incidence of cancer. So how do we do that? And can we avoid that unnecessary surgery? So a team of researchers have looked at several people who've had papillary thyroid carcinoma, examined the genetics of that thyroid tissue that was diseased, and determined what the mutations in that disease process were. And in doing so, they found many, many, many mutations. But there were some primary ones that included the mitogen inhibitor tyrosine kinase pathway, BRAF and RAS. There are other ones that were very important, the PAX8 PPAR and the RET protoncogene RET mutation. So they developed these panels that would look at these different mutations and tried to test the tissue to see if it had those mutations and see what the correlation with ultimately having thyroid cancer in those nodules would be. And they found that they could correlate fairly well. It was recommended to use these biomarkers at the time of first biopsy. It was recommended specifically for this area where I told you we fail the most, which is the indeterminate area. So there's two major companies, and I'll come back one, Afirma and Thyrosec that have really made the Thyroseq, that have made the more commercial accessibility. First, we'll talk about Afirma. Afirma has what's called a genome sequence classifier. And again, it's a proprietary combination of cassettes of these different mutations. And then they also included some mutations of known cancers and things that would metastasize to the thyroid so they could rule out it being something other than a thyroid primary cancer. So in the first cassette, it looks for genes of melanoma, breast cancer, renal cell carcinoma, parathyroid tissue, medullary carcinoma, and Hürthle cell neoplasms. Then a second round of mutations is tested, including the BRAF and RAS mutations. And they did this primarily on Bethesda 3 and 4, which is those in-between ones we talked about. And they found that with their most recent test, and they've been perfecting these tests, I see them getting better as time goes on, that they could predict a less than 4% risk of malignancy in a nodule if it was negative for their specific proprietary panels. And if it was positive, a more than 40% chance that that nodule had cancer. Most importantly would be that when they were benign, we could comfortably say to somebody that this had more benign features and maybe we could just watch this nodule and prevent cancer or prevent surgery. On the other end, we're also able to tell them what their risk of malignancy is, and by raising that, also increase our sensitivity and specificity. I wanted to give you a picture of what the report actually looks like. So again, you're going to order your ultrasound. You'll get back these TI-RAD classifications, and you'll determine if it's TI-RAD 3, 4, or 5, and the patient has significant symptoms that they need to see a thyroid surgeon or endocrinologist. But if you do order the biopsy, then they may automatically order these Afirma tests to further evaluate if those Bethesda needle biopsies come out as a level 3 or 4. So in this one, we can see that this one came out as a 4. It's highlighted in the middle. And they tested it for those different mutational panels, and they did not find any. And so they told us that our risk of malignancy was less than, I think they say 4% on there. The second page was a Bethesda 3 that was evaluated. And this one came back positive for its BRAF test, which told us that there was an increased risk of malignancy. ThyroSeq, with several of its researchers out of University of Pittsburgh Medical Center, has developed their own proprietary set of panels using mRNA and DNA. And they look at a little bit different set, more expansive set of mutations. And again, they're recommended for Bethesda 3 and 4. And they're positive, or I would say that their risk of malignancy identification for a positive test was as high as 66%. And for a negative test, we knew that there was a less than 3% risk of malignancy with a 97.2% negative predictive value. Here's their report. Within their mutational panel, they do have subsets that may convey a very much higher risk of malignancy, even in that level 3 and 4. Here's a grade 4 Bethesda test, who they stated would have a positive test and as high as a 99% chance of malignancy. So these are incredibly useful, but they do not tell us the extent of surgery or when to do surgery. They give us more information to make a good decision with our patients. The American Thyroid Association has endorsed both Afirma and ThyroSeq as tests that if the panel is negative, that we can watch and wait with that nodule as long as the clinical factors and perhaps even the ultrasound factors don't raise such concern that we feel that thyroid surgery is required. An instance where they could be negative and we would still proceed is if we saw an ultrasound some area of invasion into the thyroid into the trachea or extension into surrounding tissues. Certainly in lymphadenopathies that may have been identified as actually having metastasis. And there are many more other concerns and situations to consider. A positive test, though, also encourages another factor to decide on a surgery to perform either a diagnostic thyroidectomy or if we have more information like that last ThyroSeq, maybe even a total thyroidectomy. The American Thyroid Association recommends CLIA qualified laboratories. That's the Congress Laboratory Improvements Amendment. It's basically saying they're held to a certain standard and that hundreds of different companies don't enter this market and start lowering the sensitivity, specificity, and predictive values of the studies. So once we get these results, we put the picture together and we try to decide what's best for the patient. And if it does include surgery, it still may be a diagnostic surgical excision if we have an increased risk of malignancy, but we still don't know for sure. We certainly would shoot for half or more of our patients who have to have surgery to have an actual reason for the surgery, such as a malignancy. So thyroid lobectomy with intraoperative frozen section could be determined for these indeterminate nodules with high-risk features or positive biomarkers, rapidly growing nodules, high-risk clinical findings like we discussed about earlier, and certainly even symptomatic nodules like my lady who we thought had a more benign disease process. The problem with this is a diagnostic thyroid lobectomy can lead to a subsequent surgery. So if we take out the nodule with an intraoperative frozen section and we can't determine on the table it's cancer and leave that other lobe in, we might find out later on histopathology that there was cancer and still recommend that a completion thyroidectomy be performed, requiring yet a second surgery. So is there a time where we can just do a lobectomy and be therapeutic? There certainly is. In small thyroid cancers, we can remove the thyroid lobe if it is well contained within that lobe and it doesn't invade blood vessels or have concerning features, including pathology features such as a insular cell carcinoma or a clear cell carcinoma, or a follicular variant, all these variants of papillary, or other concerning features like invasion into the trachea. If it has more benign features, we can do just a thyroid lobectomy. But that does eliminate our option to treat with adjuvant therapy. And the adjuvant therapy for thyroid cancer is radioactive iodine. So a therapeutic thyroid lobectomy is very specifically chosen. And importantly, it is a reasonable option when all those are met and the other lobe of the thyroid is normal. So total thyroidectomy is probably the most common surgery done for thyroid. It is indicated in a malignant needle biopsy or a suspicious needle biopsy, especially when that biopsy and that nodule are present in a thyroid that has contraindications to taking out the other thyroid lobe. And those are the various things we talked about: invasion, metastasis, concerning histologic findings. Also, risk factors such as age. Over age 45, we consider those patients a little bit higher risk for having poor response to thyroid therapy. Indeterminate finding with a positive biomarker and features that avoid the option of taking the other thyroid lobe. So we're taking out the left lobe for evaluation, but the right lobe has as many nodules and maybe symptomatic nodules as the left. We may elect to proceed with a total thyroidectomy. Certainly, it's a total thyroidectomy if there's any metastatic lymph nodes, because in that setting, we're going to want to use radioactive iodine, and that would be most important for elimination of the disease. And lastly, the goal is to eliminate all gross disease. So here's a picture of our anatomy. We're all probably familiar with this, but if not, that is the thyroid gland shown there on the right, the absence of it on the left. In the groove between the trachea and the esophagus is the recurrent laryngeal nerve, and coming near the thyroid membrane is the superior laryngeal nerve over the cricothyroid muscle. So back to my lady, the 68-year-old lady who had the dysphagia, the sudden hoarseness, the rapid growth. We certainly knew that she wasn't improving over weeks and she was very symptomatic. And so we took her to the operating room and removed the gland. And this was a nice, impressive picture of a very large gland as it came out. I wanted to show a few pictures of the intricacy of thyroid surgery. Here we show the recurrent laryngeal nerve attached to this big mass that I had to dissect off of that mass in order to preserve that nerve, which controls the voice box. And then up superior and to the left is the superior parathyroid, which is above that nerve. And you can see it's a very small gland. I think we hear about parathyroid surgery and everyone would like to know what these glands look like. And they're very small and they can be very difficult in a very fatty filled neck. So here's the mass out. It was quite big. We showed a recurrent laryngeal nerve. And then here I showed a tape measure next to the size of the parathyroid, because again, it was a very nice visible parathyroid and only measured around 6 to 7 millimeters, probably at best weighed 15 to 25 milligrams. When we have disease in our lateral neck, we will also have to treat that as well. I did discuss earlier, we have to treat all gross disease. So we will do what's called a neck dissection for lymphadenopathy of the lateral neck that we are confident is metastatic thyroid cancer. The lateral neck is traversed by the transverse thyroid artery, and so it tends to form in the posterior triangle or in the posterior lateral aspect of the neck a little bit early and over the supraclavicular region. So that can be a sign also that we're dealing with more thyroid-related metastasis. Prophylactic central compartment neck dissection is something that's been of another point of controversy in thyroid surgery. And with the studies done, we've noted that the morbidity is very high when this is done without obvious gross disease. And so it is done for gross disease primarily, although that is still controversial. Here's a picture that just shows the different areas that lymph nodes lay in the neck and what that tissue looks like when we remove those lymph nodes, leaving their carotid, jugular vein, and muscles and nerves in place. So here's a picture of a patient that I had to do a neck dissection on for disease. She has absence of her jugular vein in this picture. And so what you see there is a retracted sternocleidomastoid muscle with the hypoglossal nerve under the other retractor, a long nerve down the middle next to the carotid that is the vagus nerve, and then high in the left corner is the spinal accessory nerve. All the lymph nodes have been removed. So in summary, what I want you to take from this lecture is that there are concerning features, both clinically on ultrasound and on needle biopsy, that should drive our decision-making process. I think for my primary care referrers, I recommend that if you obtain an ultrasound, that you read some of the words in that ultrasound. Look for that TIRAD score, specifically if it has a level 3, 4, or 5. Refer early, and if you are comfortable, order an ultrasound-guided needle biopsy in the appropriate settings with those concerning features. Really for ultrasound features of a nodule greater than 2 centimeters, microcalcifications, extrathyroidal extension, or irregular margins. And then on the needle biopsy, understand the types of findings that we have and when further workup with mutational and genomic testing can be available. Thank you.